North Carolina at Chapel Hill and USAID Advancing Nutrition. Thank you so much for joining us today for our first meeting of the year for the FIND COP, or the Family Inclusion and Nutrition Through Engagement Community Practice. My name is Neha Jabari. I'm a social behavior change specialist with USAID Advancing Nutrition. And if you haven't already, please go ahead and introduce yourself in the chat and share where you're from and what organization you're part of. And we'll continue to move forward with the agenda today. So today we'll be focusing on tailoring nutrition activities to family dynamics. So we will begin with the presentation. We will have time for a question and answer, and then we'll move into a breakout room discussion. And if there's time, we'll have a bit of a share out and a larger discussion coming together. And then we'll conclude with a wrap up and some Zoom poll questions. So I'm very excited to introduce Gargi Wable Grandner. She is the Technical Director of Nutrition and Food Systems at ACDI VOCA. And prior to joining ACDI VOCA, Gargi worked as a nutritionist for various academic and non-academic institutions in South Asia and Sub-Saharan Africa, where she contributed to global food policy and maternal and child nutrition research, programming, and advocacy. Her areas of expertise include dietary data analysis, mixed methods research, and social and behavior change communication. She has extensive experience developing tools and survey instruments to support nutrition-focused capacity building, project implementation, and monitoring and evaluation. She holds a PhD in nutritional sciences from Cornell University, an MS in food policy and applied nutrition from Tufts University, and an MSc in dietetics from University of Pune, India. So now, without further ado, I will turn it over to Gargi to begin her presentation.
Thank you so much, Neha, for the introduction, and I'm so delighted to be here. Thank you, FIND COP, for inviting me for this presentation and the discussion. I'm really looking forward to it. So I'm going to share my screen now and advance the slides. Neha, please let me know if anything does not go according to plans. So here it is. Okay.
Yeah.
Okay.
We are able to see it, so perfect.
Great, thank you. I'm just going to. All right. So today I'm delighted to present an example from rural Bangladesh that involved some form of tailoring of nutrition behavior change counseling. And this work was recently published in Maternal and Child Nutrition Journal, which I believe the audience here has had the chance to go over. In this paper, we tried to explore how one-on-one interpersonal counseling is tailored to persuade family members with influence on nutrition behaviors. Because this paper was already shared, I think in the interest of time, I will focus on why we conducted this study, the methods, and also the some of the findings and the implications for those of you involved in family-focused nutrition interventions. Okay, so the premise of this study is the knowledge that we have gained through family-focused interventions so far, and the understanding that within a family, members have different subjective realities. And these subjective realities are based on traditional roles, knowledge and beliefs, and motivations that differ across family members. So if we see the illustrative figure on the left, say, for example, in Bangladesh, nutrition interventions often target the pregnant and lactating women who are childbearers and duty bearers within the household, meaning they conduct most of the household work within the household. Then there's the mother-in-law, who is the household manager, and the family, maternal and child health advisor traditionally. And then the husbands, who are the primary income earners and food procurers, meaning they decide what food to buy and what, so they basically have decisions on what food to procure into the household. Because of these varied traditional roles and the motivations that may come because of the cultural experiences of these different family members, family-focused counseling should focus not just on the content, meaning the what of what we are trying to convey, but also on the approach or the how to persuade individual members with influence. So fortunately, while we were thinking of this study, in 2015-2017, a focused intervention on mother's nutrition took place in northern Bangladesh. In this intervention, community health workers from BRAC, which is a well-known non-governmental organization, already had this cadre of female community health workers implementing maternal and child health programs. But in the period of 2015 to 2017, a very focused, comprehensive maternal nutrition intervention was layered on the current work that they were doing as community health workers. So that involved monthly home visits to pregnant women and meeting the women and all family members, specifically the influential family members, who are meaning the mother-in-law and the husbands, to counsel them on different aspects that promote maternal nutrition. And the various topics that were covered were maternal diet, rest and workload during pregnancy and postpartum, gestational weight gain, and micronutrient supplements. This program was designed by Alive and Thrive, implemented by BRAC, as I mentioned earlier, and was evaluated by the International Food Policy Research Institute. Other notable features of the maternal nutrition intervention that I would really like to mention that community health workers attended monthly meetings in the intervention areas. And there were husbands forum where there were group-based peer exchanges among the husbands of the primary targets, the women who were pregnant at the time. And it is also important to note that this intervention did not involve any food or cash support. So it was mostly a social behavior change intervention that included interpersonal counseling by community health workers and husbands forum to kind of change some social norms around maternal nutrition. Within 1 year of the program, the impacts were, I would say, really impressive, although they were mixed. And here are some of the details. There was improved counseling coverage and quality in the intervention areas, improved knowledge and engagement of husbands. And in terms of the outcomes, there were improved maternal knowledge, improved maternal diet diversity. There were improvements in exclusive breastfeeding, but not in early initiation of breastfeeding. So as I said, there was mixed impact. However, what remained unknown was community health workers' own experiences from the pilot intervention. Specifically, who did they counsel and on what? What insights could they share on family members' motivations and the barriers and facilitators in counseling? And what strategies did community health workers use to improve family support for behavioral recommendations? Today, I will talk a little bit about the last two study objectives that we had. For data collection, we randomly sampled 35 community health workers across 7 sub-districts. The intervention took place in 10 sub-districts. Semi-structured in-depth interviews were conducted one-on-one with community health workers, and there were participant activities involved because we really did not want to focus on the content of their behavior change communication, which we already had from the program designers. So we really wanted to focus on how they communicated or how they kind of convinced family members to adopt those promoted behaviors. And for that reason, we actually created these small notes with each sheet of paper with each message that was promoted during the program. And I will talk more about it, but as you can see in the figure, that was the raw material, so to speak, for this study. Once we collected data, the interviews were transcribed from Bangla to English, and we performed iterative coding and used Fisher's narrative paradigm for our own analysis to structure the findings. In terms of the sample questions, to understand what motivated different family members, we used the behavior change messages that were motivational. There were 4 total messages, and we asked the question to community health workers, in your experience, which benefit convinced most mothers or husbands and mothers-in-law to adopt or support recommended behaviors, and why? To get to the barriers and facilitators, we included pile sorting activities. There were 2 pile sorts. In the first pile sort, we gave them the list of messages that I just showed you in the previous picture. And individually, they could sort what was difficult versus easy to deliver and why. And in the second pile sort, we asked them, what did you perceive as difficult versus easy for mothers to adopt and why? And although we did not collect data on the beneficiaries or the participants of this program, because by the time we started this study, the intervention had wrapped up, we wanted to understand community health workers' perceptions, because they were the ones who were going door to door to performing household visits. So they, by the time in the 2 years, they had gained a lot of experience. Once the community health workers were able to sort those messages into, what was difficult and what was easy, we asked probing questions such as, why was this message difficult to adopt by the mothers, or for them to promote, for the community health workers to promote? How did you overcome the barriers that you or your clients encountered? And how did you counsel your clients to address such barriers, which I think was the key question asked in this study. I believe this in the paper that was already circulated, you read about Fisher's narrative paradigm, which calls for the coexistence of argumentation with creative storytelling to persuade an audience to think or act differently. In this paradigm, Fisher emphasizes on 3 pillars of persuasion to present an audience with good reasons to think or act differently. The 3 elements are ethos, which is the credibility of the communicator. Second is logos, which is the logical arguments or content of the communication, or the what of what we are trying to communicate. And pathos, which is the emotional impressions evoked by how content is communicated. And based on their subjective realities, which differ across family members, individuals accept or reject good reasons by assessing the narrative coherence, which means, does the story hang together? And narrative fidelity, which means how, whether, and for whom a story rings true. So for example, if I say that, eating better during pregnancy would improve weight gain and would lead to a healthy baby, it may ring true for a new mom, but it may not ring true for a mom who's already had a baby without a healthy diet. So narrative fidelity really takes into account the previous past experiences of the audience. Moving on to the results. There were motivators of family members to support. When we tried to explore the motivators, certain motivators were common across all family members. So for example, the key motivator for all family members was improved fetal growth. Everyone really wanted a healthy baby, and which is understandable in any family. And then, but on the other hand, the least motivating outcome for all was improved maternal health. And this sort of then prompted community health workers to create stories to improve support for maternal well-being by using the garb of a narrative focused on child well-being. And this is something we heard from nearly all community health workers. And one of the quotes I wanted to use to illustrate this is, we have to create such stories to make them understand. We have to do that in the field if we want them to accept what we say. Again, community health workers were really motivated to, bring about the behavior change and bring about the improvements in maternal nutrition. But for them to do that without any kind of food and cash support, they really had to present convincing arguments to their audience. And so one of the ways they did that was to use the garb of a narrative focused on child well-being. Secondly, there were motivations that differed across family members. So for example, for husbands and mothers-in-law, saving medical costs on mother and child was really important. So these differences in motivations prompted tailoring of messages through strategic use of logical arguments and appealing narratives. And some of the examples we'll see in the following slides. Before we go there were also differences in how community health workers were perceived, or their credibility as health and nutrition promoters were perceived. For mothers, they were used to having community health workers visit for the maternal and child health program prior to 2015, so they had positive trust-based relationships. However, the new targets, meaning the husbands and mothers-in-law, did not initially, follow the advice that community health workers promoted. So initially, husbands resisted community health worker advice, especially if they're asked to bring more nutritious foods and, fulfill follow the message of letting their wives consume 5 different nutritious foods without monetary support or without food aid, was really difficult for them to kind of just follow that advice. However, because there were husbands forum, Those peer exchanges helped improve perception of community health worker credibility. On the other hand, community health workers expressed that mothers-in-law throughout the project mostly viewed them very negatively because traditionally they are the MIYC and advisors in the family. And when community health workers have promote messages that contradict their understanding or their beliefs, they did not view community health workers very favorably. However, during the pre-service training, community health workers were trained to use respectful counseling and use simple village language. Now, what kind of simple village language, they were not told about that, but they were asked to be patient with elders and use simple village language. That was the general guideline given to them. But one thing I wanted to really highlight is how Husbands Forum, in addition to the interpersonal counseling, really helped kind of like, maneuver the family dynamics. So for example, this illustrative quote says, "We counseled husbands, and in that regard, husbands meetings helped us a lot. Fathers-in-law just follow what the mother-in-law says. So if husband and wife are equally informed, then what we say gets more importance because everybody listens to their son or son-in-law." And here you can see like the gender-based hierarchy or the family dynamics that emanates from gender differences. In terms of whether messages were perceived as reasonable, I just have an example on maternal diet here. The paper covers examples on maternal rest as well as breastfeeding. So husbands were generally persuaded by logical arguments or visual proof because they could see if their wives' weight gain during pregnancy increased, and if supporting their wives with in higher dietary intake and dietary diversity led to those kind of improvements in weight gain. They appreciated concrete examples on procuring low-cost nutritious foods, which community health workers were trained to promote, and they emphasized that, which they kind of repeated that was already something that husbands heard during the Husbands Forum. In terms of the primary client, who was the pregnant and lactating mothers, they acknowledged logical arguments, especially if they were educated. However, logic was insufficient for some mothers. And on the right, there is an illustrative quote that I have shared, and this emanates from the internalization of gender-based norms. So for example, the community health worker shared that it was very common that mothers did not eat an entire egg. They wanted to share half of it with their husband or son. And I asked, why did they want to share it with their husbands? So community health workers explained, well, these are village women. They are not accustomed to eating the whole thing alone. They don't even think about it. So here you can see the internalization of, putting yourself or eating last and least that we've heard in the literature. And then in terms of mothers-in-law, they did not seem to be persuaded by logical reasoning of, higher food intake, and then would lead to better gestational weight gain and better birth weight of the child. They actually viewed higher food intake as, leading to higher weight gain, which would then complicate delivery, and that they would increase the risk of cesarean section. So that was their normative belief. And so the narratives of community health workers or the logical arguments did not really convince them of improving maternal diets, for example. And then it comes to tailoring of messages to targeted audience. Again, this tailoring I mentioned already, that was essential to satisfy the motivations that each family member had to support the behavior change to improve maternal nutrition. So one of them was using contextually relevant metaphors. And this is an example of how I mentioned before that community health workers were just advised to use simple village language. So here's an example where a community health worker explains the way she counseled a mother-in-law. She says, "Look, grandma, when your cow gives birth, you give that animal so many foods as part of your special care. If you can take care of your animal in postpartum period, why would you feed your daughter-in-law who has just given birth to a baby only rice with salt and eggplant? Why? These things are outdated now." And then, as I mentioned earlier, using the garb of child well-being to promote maternal well-being. So a lot of community health workers shared how they made everything about the baby. For example, I would say to my clients, listen, Appa, try to eat at least one piece of fish. Keep in mind that you are pregnant and are bringing a baby into this world. So you are the one who needs to eat well. And this was really important because, as I mentioned, mothers themselves had this tendency to eat last and least, even when they were pregnant or during the postpartum period. Focusing on baby's intelligence also was an important strategy that community health workers use, given that everyone, the hopes and desires to have a better future for the family. So, for example, one community health worker shared, we would tell husbands, please buy foods like eggs, fish, etc. for your wife every day. It will also reach your baby through breast milk. That will help develop the baby's brain. Don't you want your baby to have a good brain? After counseling them like this, the insured mothers ate fish. However, we do also want to highlight that tailoring of messages can create challenges, especially if community health workers are promoting inaccurate but contextually appealing advice. And an example of that is here in terms of breastfeeding. Mothers-in-law would say, what harm can a little bit of water or honey do to a baby? The baby is crying. So we told them not to give even a single drop of other things. Otherwise, the baby's brain capacity will be destroyed, which we all know is not really accurate. But this is how they tried to convince mothers-in-law to, not practice prelactal feeding, for example. This type of tailoring was encountered across all three topics, which is concerning, but it was more frequently found in case of rest, which again is very hard to promote in the daily lives in a rural setup where mothers are often living alone while their husbands have migrated to other places, or they have a lot of responsibilities in terms of childcare, housework, on-farm or off-farm work. But in order to kind of convince them why they should rest, messages such as the baby is at peace if mother rests, baby gets oxygen when mother rests, or baby's intelligence will be reduced if the mother works constantly, were shared by the community health workers, which was really concerning and one of the key findings, I think, from this paper. So the key takeaways from our study are that insights from community health workers experiencing family-focused counseling can help understand the gaps between what is promoted and what is accepted, which again leads to a better understanding of why there are mixed impacts, that some behavior change messages are accepted better, and you can see the impact. For example, like I mentioned in this intervention, maternal diet diversity improved, but certain behaviors such as early initiation of breastfeeding did not. Community health workers' insights revealed in this the second key takeaway is that community health workers' insights revealed that the importance of building trust among all counseling targets within the family unit is important. Second, the receptivity to the logical content of nutrition BCC messages among different targets. And most importantly, tailoring of counseling narratives when logical content is insufficient for persuasion. However, it is also important to note that although tailoring helps when audiences' traditional roles, motivations, and beliefs differ, care should be taken to avoid dissemination of scientifically flawed messages, because then that becomes a new norm that we in public health practice would have to work to avoid passing from one generation to the next. So the implications, I think, and I'm happy to discuss this further in the group discussion for future family-focused programs, that post-training, programmers need to assess how frontline workers package recommendations to appeal to different family members. And this would involve not just supervision of counseling narratives, but also regular monitoring of what is discussed in those community health worker meetings, because they are talking about what they find difficult and how they're addressing those challenges or difficulties. But the care needs to be taken that the inaccurate messages are not spread through the program. And the second implication is that interpersonal counseling could be complemented by group-based interventions that reach all influential family members to build their trust in the health system. engage them in dialogue to improve perceptions of healthful behaviors, and address gender-based expectations and shift away from harmful social norms. For example, in case of rest, where rest and workload is really the domain of the younger mothers, and how can we actually have group-based dialogues to see if husbands can help somewhat in alleviating that burden, especially during pregnancy and postpartum. Here are the acknowledgements. I really would like to thank the team at BRAC. I had such an honor to work with all the community health workers who participated in the study and the supervisors, and especially Dr. Kausar Afsana, Nazia Islam, and Sadia Shabnam, who were part of the program management team for making the study possible. The Alive and Thrive experts, Dr. Zeba Mahmood, Dr. Tahina Sangvi, researchers at International Food Policy Research Institute, Dr. Rasmi Afula, Dr. Fong Nguyen, who's been really inspiring, has published a lot on Alive and Thrive maternal nutrition intervention in Bangladesh, and Dr. Sunny Kim, who's also published a lot on the IYCF-focused Alive and Thrive interventions, and all my co-authors and friends from Cornell and beyond. Thank you.